Good morning, everyone, and welcome to CME Palooza Spring. This is our second session. I'm Derek Warnick, one of the co-producers of CME Palooza. Let me bring up our slides here, and we'll make them full screen so everyone can see them good. All right. So this is our Surviving 2021 Lessons Learned from Surviving 2020 session, sponsored by Peer Audience. This is a continuation of a session that we had back in the fall. So very excited to have another go around at this session. We have some great content for you, so let me get through these quickly so we can get into the good stuff. Moderator today will be Angelo Carter from Pfizer once again. Before I turn things over to him, though, of course, the recognition of our sponsors, who we are very thankful for and helping us make this a successful program. Our gold sponsors, MedLearning Group, Physicians Education Resource, PER, and Projects in Knowledge. Our silver sponsors, Peer Audience, Academic CME, ACHL, Integrity Continuing Education, Hippocrates CME, Platform Q Health Education. And our bronze sponsors, Antidote Education Company, PVI, CMEology, Haymarket Medical Education, Vindico Medical Education, Medscape Education, RMEI Medical Education, Global Education Group, Real CME, Answers in CME, Helio CME. Creative Educational Concepts, Integritas Communication, Infograph Ed, Prova Education, DKB Med, CME Outfitters, Evolve Medical Education, Spire Learning, Red Med Ed, Foresight Learning, and Excalibur Medical Education. As always, there are two ways that you can ask questions. You can use the Creative Educational Concepts, or CEC text line, to send in questions, 267-6660-CME, and you can tweet your question using the CME Palooza hashtag. I'll be monitoring both of those, so feel free to use either one. We also have our Peer Audience Response System. We're using Poll Everywhere. We do have a couple of questions for you. Hopefully you use that during the first session. But if not, you can either do it by the app using the code there, CME Palooza 005, the Poll Everywhere app. Or you can plug in that URL into your browser. I would say to go ahead and get that prepared. We do have 2 or 3 questions for you to respond to later on in the session. And then our last slide, speaker disclosure. Any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or a position of their employer, its parent company, or affiliates. And with that, I'm going to turn things over to Angelo. Take it away, Angelo.
Thanks, Derek. What we'll do is first introduce our panelists. We have Lionel Phillips, President, Inside Edge Consulting Group. We have Dr. Charles Vega, Health Sciences Clinical Professor, UC Irvine Department of Family Medicine, Assistant Dean for Culture and Community Education, Director of UC Irvine Program in Medical Education for the Latino Community, and Dr. Fernando De Mayo, Director, Health Equity Research and Data Use, American Medical Association. So welcome all, and welcome back, Lionel and Charles. A lot has happened in the last 6 months since our last CME panel discussion, where we discussed surviving 2020, talked about COVID, and looked at social justice issues and the impact of health of underrepresented communities. And, you know, my first thought was, and like many people, 2020, we're now into 2021, and hey, I made it. We made it. But as we all know, there are so many different things that have happened. There's a number of approved vaccines now. There's been changes in the administration, school reopenings, restaurants, hybrid models, all kinds of things have happened, and still a number of different types of barriers. So I'm excited today with all of you to start talking about 2021. But first, I'll start with you, Lionel. Any initial thoughts as you reflect back at 2020?
Yeah, Angelo, again, thank you so much for the opportunity to come back and join this esteemed work and to be among such an impressive panel. The first comment that I can make is, wow, we made it, to your point. But I found that that 2020 was truly an inflection point, in healthcare. And with what happened with George Floyd, the pandemic, it really forced our business, the pharmaceutical business, to really revisit how it thinks of the underrepresented population and revisit it from a internal perspective. That means what happens within their organization, then also how they can best engage the community themselves. So from an outside perspective, I found that beyond just having conversations about the underrepresented populations, particularly those that are Black as well as Latinx, there's been a lot of work within pharma about how do we do something in an intentional way or a meaningful way. And it's about how do we staff properly within the business, and how do we make sure that diversity and inclusion becomes a staple part and a measurable part of the work internally. And then a lot of work has been done, during this time as to what are some of the new partners that we can have, both from a vendor standpoint, as well as how do we look at communities and how do we better engage communities through community advocates and things like that. So I thought that was pretty fascinating. And I think to that extent, there's been some successes, but as we all know, there's still a long way to go. And medical education, I think, is a key driver to that and can certainly be helpful. So I think some of the things that we may talk about today are things that really would include some of our audience and how they can help in terms of driving more awareness and better work in the underrepresented community. So I'm grateful to be part of this panel today.
Thanks, Lionel. Same thing, Charles. Any initial thoughts as you reflect back to 2020, or as you look now? As you look back?
Yeah, my first thought is never again, never, ever again. But I agree with Lionel, and thanks as well for being on part of this panel. It's always great to be with a group of very thoughtful and constructive individuals. We deal with a real severe problem, the one that's not going away, and one that was laid bare in 2020. And so I think my take home is, yes, congratulations. We've made it so far, but we have to keep striving. So many plans got derailed last year due to hardship and pain and suffering, which we saw everywhere. And it did feel like the walls were closing in, and darkness really fell upon us. But I did find that it was a good time to fall back on those fundamentals, the relationships that I have with patients, the relationships I have with families and community. That moves the needle. That's something positive, even in the darkest of times, that we have one another, and even making those smaller efforts, on a one-by-one, or I'm taking care of a family who all have COVID via telehealth. That makes a difference too. And I think it's important to realize those differences because we work hard at them, and so we should give ourselves credit for those. And that also sets us up for the larger goals. When we talk about improving health disparities, when we talk about health equity, I don't think we can get there if we don't maintain those fundamental types of relationships. In fact, that's really what inform us and should give us the energy to move forward. So I feel very positive about 2021 and moving forward, but it's not going to be easy. It is going to be a struggle, and we need to do it in partnerships with patients and community.
All great points. Like I sit back and I think a lot of us have done a lot of soul searching and thinking about family and not being able to visit, as well as the strength of family and community. All great points. Fernando, welcome to the team. I know you weren't with us last year for the discussion, but you definitely have a passion in this space. Any initial thoughts about 2020 when you reflect?
Sure. Many thanks, Angelo. And indeed, many thanks for inviting me to be part of this panel. I'm really looking forward to the conversation. So I come at this really from perhaps a different perspective. I'm a PhD in sociology, and I look at the world primarily through the lens of structural violence, right, of social and political arrangements that harm populations. Right, the violence in this case is COVID, but it's been life expectancy, it's been infant mortality, it's been heart disease and cancer, and all of the major killers in our society. So as I try to kind of think back through 2020, first, of course, like many, like all of us, first I'm struck by the harm, right, by the incredible toll that we as a society have paid, right, and that's clear in our population health indicators and the death toll that we're all familiar with, and it's also very present in the strain, right, and the strain felt in our healthcare system and in society at large. We're certainly not out of the woods just yet. And I'm trying to reconcile thinking and acknowledging that harm that we've collectively experienced with the positives, the inspiration. Charles just mentioned relationships and partnerships, which we knew were vital before and have taken perhaps even more fundamental importance now as we enter a post-COVID world. In Chicago, where I'm situated, I think we've seen many of our institutions come together in this way, right? Our leading healthcare institutions came together to issue a very strong statement against structural racism in the summertime. The mayor quickly stood up when the first data showed a disproportionate hit on Black and Latinx communities from COVID. The mayor's office quickly stood up a racial equity rapid response team that did remarkable outreach, intervention, data work, and that brought together people in existing and new relationships and partnerships. And I'm hopeful that will pay dividends, not just in 2021, but in the future, right, as we tackle health equity, not just from COVID, but from other causes of death as well. So again, thrilled to be with you this morning, and I look forward to the conversation.
All right. Thank you all for your initial reflection. So I think we just should jump right in. We received a number of different questions, or I guess pre-questions from many individuals that are on the line. So let's jump in. I'll start with you, Lionel, first. What do you think are the most critical educational needs with respect to promoting health equity? And again, panel, let Lionel start off, and please feel free to jump in.
Yeah, thank you, Angelo. That's a perfect question for this topic. And I would suggest that it's really about doing a better job in doing direct-to-patient education. So direct-to-patient education, I think we do a lot of education with healthcare providers, but at the end of the day, it's the patient that we're all working toward improving health around. And there is such a void in the area of trust. And there's so many different models, from the coach model to others, that give us an opportunity to educate and develop medical education programs that can be impactful around trust. Telehealth is here to stay. And we all know that although telehealth has certainly provided some advantages, maybe there's some risks there as well, because not seeing the doctors as regularly as we have, or healthcare providers that are already a part of this group, could be a challenge. And educating on how to make sure that telehealth is augmentative can be a nice topic, particularly when you're looking at health equity. I, as part of our business, have used Zoom a lot in terms of educating patients and the community on their health. And we all know with COVID, particularly those that have cardiovascular disease, those that have oncology or hematology, disease and risk, those topics really go really well, during Zoom health conferences directly with patients. They garner large audiences because there's a tremendous amount of interest in those kind of topics. The COVID vaccine, a lot of interest in those topics. So you can have hundreds of people on Zoom. And we all know that no matter what the age of the individual, Zoom has become part of our culture. Our parents meet with their kids and grandkids through Zoom. We do it through our religious and faith-based organizations. And marrying some health education as part of the Zoom culture, I think is very helpful in terms of breaking down some health equity challenges and bringing more information to the community directly around, how to improve their health. So those are some immediate ideas that I have. I think certainly engaging community advocates is really important. And the last comment I would make is that, we ought to challenge ourselves. And, one of the things that I know that for me and the business that, again, we have is that we do a lot of medical education work. And do we do enough in terms of including underrepresented populations as part of our medical education? Something to certainly consider is an important topic that certainly we all can fill a void against.
No, thanks, Lionel. I think a lot of good points there, especially when you look at the relationship between clinician and patient and communication of how that's been affected in light of COVID. And, I think everybody's been on Zoom or other types of platforms of how we communicate. And we know there's going to be a number of changes and use of technology. Charles, Fernando, anything to add?
Okay. I think Lionel points are incredibly well taken. I know how important it is to do community education and to make it meaningful to them. I think with the cultural and linguistic fluency, particularly in a community like ours in Santa Ana, California, is really critical. And using community health workers, folks who can reinforce the message and talk about from a personal level, and understanding what's going on at the neighborhood level is really important as well. But I really want to see outcomes. I don't think education can get there alone. We really have to be creating systems of care and public health and healthcare access that are meaningful and lasting, and really focus on those that have been left out. So this goes back to who are we hiring? How are they trusted by the communities that they serve? There's ways to measure that. What are the outcomes? Who's getting health maintenance? Who's getting their vaccines on time? And so trying to create some systems around that educational model so that reinforce one another. I think that's what's really going to move the needle. And so really start with outcomes and then work backwards towards methods that will be most effective at improving health equity.
Yeah, those are really great points, and I really appreciate the need to center outcomes, because that's really what we're all after, right? It's not just the standing up of more programs and centers or institutes or initiatives, but it's to make substantial change. And I think central to that is the recognition that health equity is not a utopian dream, right? That we tend to think of health inequities as deeply entrenched, and they are in society. They're deeply entrenched in our history and our politics and our economics. It's huge, horrible, heavy problems, but they are dynamic, right? If we look across place and across time, patterns of population health change quite a lot. Centering that within medical education, I think, is really, really important. Otherwise, it's too easy to dismiss health equity as a utopian dream. One project that I'll quickly mention is a book that I have coming out with some fantastic colleagues at the Sinai-Urban Health Institute here in Chicago, called Unequal Cities. Structural racism and the death gap in America's 30 largest cities. And there we took a look at mortality data for our 30 largest cities and found remarkable variation in Black-white inequities in life expectancy, all-cause mortality, premature death, and then cause-specific mortality from the top 10 leading causes. Really understanding that variability, understanding why Chicago is worse than just about every other US city and actually growing in terms of its gap, I think is of vital importance, not just from a research perspective, but from an action perspective as well. And how we integrate that into medical education, into public health education, is a vital task. The other component that I would put on the table as being central to reimagining and strengthening educational needs is the need to center structural competency, right? The trained ability of physicians to not just treat the patient in front of them, but to recognize the social context, the structural drivers that are shaping their life, that are constraining their ability to make healthy choices in many cases. Structural competency, one of its core components, is the idea of structural interventions, right? Recognizing that we can't really move the needle on health equity if we focus on biology, beliefs, and behaviors, that we have to recognize the root causes, the structural and community level determinants that shape population health. And we can do that with humility, recognizing that the healthcare system by itself cannot address all of the problems in the world, but it can work in partnership, right? It can work in partnership with community members, with professions and disciplines outside of the healthcare system to really make a difference. And I think that's hopefully some of the changes that we'll see in medical education in the future, a recentering and a rebalancing between public health and medicine for the benefit of all.
I think all great points. And Charles, I think you nailed it on the head with the outcomes. And when you look underneath the overall type of umbrella across the board to understand what's working, what's not working, and looking at what can be sustainable, what can expand across the board. And, Fernando, what you just mentioned about data, I think everything is data driven. And I know you mentioned about 30 different cities and what you're examining. Is that coming out this year, this type of research, or is there a timeline when that type of information would be available?
Yeah, thanks, Angelo. Yeah, we just had a paper come out in JAMA Network Open, looking at all-cause mortality inequities across the 30 largest cities. And then we have a book version of that coming out with Johns Hopkins University Press this September, part of Daniel Dawes' Equity in America series. So we're really excited by that and the potential to then partner, right, with health systems and organizations in each of these cities to not only understand the landscape, the data landscape, where we're at and where we've been the last 20 years, how these patterns have been changing, but then strategize together on how to make changes in the future. The data is so powerful, right? For example, in Chicago, we have an 8.8-year gap in the life expectancy between Blacks and whites. That's a gap that is growing over time, that will grow with COVID. We can do a decomposition analysis of that life expectancy gap, and we find that the bulk of it, the majority of it, is driven by heart disease and cancer, things that our healthcare system can and should more equitably address. Only a fraction of that is homicide, which tends to make our newspapers and is seen as the problem in our city. The main drivers of the inequities are the more mundane, everyday killers that we see in other populations. They're just striking at earlier ages and in disproportionate terms. So I think if we can get a handle on that kind of data, and importantly how they change over time, we'll have a far greater insight into health equity. One last example that I would give if I have a second, and this comes back to a study we did a couple of years ago comparing community level patterns in Chicago and Toronto, which at first glance might seem like an apples and oranges comparison, right? Different health systems, different welfare systems, different populations. But that was part of the point, to see how different things could be. Among our Chicago communities, as you might expect, we have a very steep association between racial ethnic composition, particularly non-Hispanic Black, and low birth weight. Similar associations with unemployment, with educational outcomes, and other social determinants of health. Very steep lines. If we did that same analysis among our Toronto neighborhoods, and we found no association whatsoever, right? To be sure, there are lots of poor communities in Toronto. There are very segregated communities in Toronto, but they have just as good health outcomes as the majority white communities in Toronto. And again, that shows us how different things can be, even within a system, a capitalist system, even within a large urban center. Far different levels of health equity are possible, and that I think is really vital.
Thank you.
Yeah, Fernando, I just want to comment that I'm going to read your book because I've been working in the space for quite a while, and I always thought that health equity was a utopian dream. So this is that's really amazing, and to be able to, I think, see things a little bit differently, particularly when we're kind of locked in our biomedical point of view, can be really inspirational. And I always think of it like we're just going to continue to struggle. We're going to keep climbing that mountain, but maybe you can show us a way we can actually get to the top. That's just, I think, if nothing else, that's going to provide us a strong way forward and even more inspiration to do this good work. So thank you.
Thank you. Derek, you said there was a comment from the audience?
Yeah, I can't, on our CC text line. I don't think it's really a question, it's more of a comment. I think that maybe this is more towards what Lionel was saying earlier. that direct-to-consumer marketing from a health department perspective versus a pharma company is very interesting thought regarding decreasing health disparities. So just wanted to put that out there.
Perfect. Derek, can we go to the, I know we got a poll
Yes.
everywhere question, so if we can go to the first.
Give me 1 second here.
Okay, so panel, I'm going to read the question, and Charles, I'll have you jump in first. And what's going to happen is these are live feeds, so we'll see some reactions from the actual audience. But Charles, please feel free to jump and start talking about it. And again, it's just no right or wrong answer. Just give us a flow or understanding of what the audience has experienced. So over the past 6 months, do you think the impact of social justice issues on the healthcare of underrepresented communities has had a negative impact, positive impact, or no impact?
So yeah, it'll be interesting. So I hope everybody votes, because I'm really interested to see what the poll is. So, but I can share while the results are coming in. You know, my personal opinion is that that there has been a positive impact, as long as you put a large asterisk right behind it, that we still have, as I mentioned, a long ways to go. And COVID-19 was such a game changer. When have we ever thought as a country, like from the moment we get up in the morning till when we go to bed at night, we're thinking about health issues now. We have to work on our social distancing. We have to remember our mask. We have to think about how what we're going to do during our day and infection control throughout that day. So it's really made everybody, I think more about health in general, and then also about others. When we see so many people dying, when we see hospitals overflowing and forming field hospitals outside, this is stuff that captures the public consciousness, and it's clear what a severe toll COVID took on poor communities, and particularly poor communities of color, and particularly Black and to a lesser degree Latinx communities. So it has been a wake-up call. It's laid bare all these disparities and inequities that have existed for many years, and unfortunately, it's costed hundreds of thousands of lives. And so that's gotten a ton of attention, and I think I see a difference in the conversation. I see a difference in the policy and in the methods in terms of, say, outreach with the vaccine being done differently with the experience of the past 6 months in mind. But while we have this pandemic, terrible illness going on, there's still the endemic issues of poverty and powerlessness. And those also need to be addressed. I think if you're really going to get to some of the root cause of some of these health disparities and really help people achieve that health equity, you have to address opportunity. You have to address enfranchisement. You have to address access to care, especially preventive care. And so this is, these are ongoing issues. But I think as the last 6 months, as dark and terrible as they have been, I think they do give us some reason to focus, and there is hope for the future.
Yeah, those are all great points. And I'm not surprised that the results as they're coming in are very mixed, right? Because we can all interpret this question in slightly different terms, and we can all possibly see different kinds of outcomes emerging from what's happened in the past 6 months. I think on the positive impact side, I would certainly recognize that many health systems, institutions, including the American Medical Association, have published strong statements that they've never published before, right? Acknowledging the existence of structural racism, naming white supremacy as a fundamental driver, right? As the ultimate root cause of many of the community level issues that we see in our society. That certainly is not going to change the world in 6 months, but it can potentially change our systems, our structures in the long term. So the true impact of that is still to be determined. The negative side of that would be if all of these statements are just statements, right? And they're not lived up by actions later on. That will cause harm, because that will cause more distress than the long term. So I think the true verdict is still to come in. But it would have been unethical, it would have been inappropriate and frankly wrong to not acknowledge the deep intersection between social justice and healthcare. we've all known that these things are intertwined for many, many years, that health is social justice. Explicitly naming it as such, I think, is the right step, and in the long run will make us a better society.
I'll just add a quick comment to what's already been served up and take it from the pharmaceutical company perspective. It is truly the first time that I've seen from the top of the organization straight to the bottom of the organization, pharma, there's been some action around social justice. And to get strong, confident commitments from the C-suite on investing in health of underrepresented populations because of social justice and understanding the correlation is powerful. And then putting some money behind that action, developing in some companies departments to look at DEI, diversity, equity, and inclusion as a pillar for a measurable change internally, as well as how they engage the community. So I think there's been some progress and some success. So I do think there's a long way to go. I do sense that there is a need to keep this front and center because it's a topic that can get buried with all the other things that are relevant in healthcare. It's too early to let the foot off the gas, if you will, because there's so much work to be done. But I do see some significant positive activity within healthcare that can provide some promising change long term.
Yeah, I would agree. I mean, all great points. And I think, as everybody mentioned, depending on where you are, what your conversation, how you look at healthcare can be different conversations across the board. I do have to say, as Lionel, as you mentioned, and looking at my peers in the industry, I have heard a lot more call to action where it hasn't been just lip service across the board in pharma, where there have been actual deliverables, metrics set that I have seen more from a C-suite perspective. And it's not as if social injustices have not been going on for years and years, but, because of different things that we have seen, I have seen a lot more commitment in addressing a number of different issues across. So again, I think it's a topic. It'd be great, Derek, to talk about this again in 6 months to see has something changed. But I think if we don't talk about it, we're not going to see change and bring up examples of what's working, what's not across the board. So all great points. Derek, I would say let's go to the next poll everywhere question. And Fernando, I'll have you start speaking. I'll read it, and then we'll see the answers or see what the responses look like. When it comes to addressing vaccine hesitancy in the Black and Latinx communities, which of the following voices is the most critical to hear from? Healthcare providers, community leaders, religious leaders, family members?
Yeah, also a great question. And my prediction will be that we'll also get a mixed response here. Because the truth is probably that all of these actors are, of course, vitally important, and they're all needed if we're going to make a difference. I think the one thing that I would really contribute to this conversation is that as we think about vaccine hesitancy, we have to think in the long term about how that mistrust has been generated. And it's not a problem of Black and Latinx communities, right? It's a function. It's a problem with the healthcare system and medical science and our deep history of scientific racism. And it goes way back, but of course, it's not just a problem of Tuskegee. People remember more contemporary acts of discrimination that have generated mistrust in the healthcare system. People remember when a woman was dumped by a Baltimore hospital a few years ago in the cold, right, in a hospital gown. These stories, these actions, this harm circulates in society, and it generates mistrust, it generates conflict, and it generates eventually things like vaccine hesitancy. How we overcome that is with humility, right? Recognizing past harm, past wrongdoings. The AMA, for example, is undertaking a whole program of work to acknowledge the harm that we have caused in the past, through support of segregation and discrimination against physicians of color in particular. And I think if we're really going to address vaccine hesitancy, as a society, we have to do that kind of truth and reconciliation work as well, recognizing that the trauma, where it comes from, and recognizing that there's no easy fix, that trust is easily lost and not so easily gained back. Steps towards doing that is to do good science and good health communication, right? Being very transparent about the epidemiological hit of COVID, being very clear about the vaccine benefits, and the real harm that will emerge if we don't vaccinate the whole population, right, of preventable morbidity and premature mortality that can be prevented in this case.
Yeah, and Charles, I know you're in the right there on the front lines in the community. Anything to add?
Yeah, I'm a huge believer in vaccines, and being a family doctor, I provide them all the time. It's one of my favorite things to do because it's such a little cost for such a big gain in terms of personal health and public health as well. And I'll say that the pattern of resistance that I see with this vaccine is different from every other vaccine. Like, I wish I could say I had 100% vaccination rates among adults in particular. I don't. But I feel like my rates, exceed the national averages. But, so I think back to a patient I had a few weeks ago, and in our clinic, over the past couple months, we've, like, every now and then around 5:30 p.m., these golden tickets kind of float down. What it is one of the vaccines has not been used. Somebody didn't make their appointment, and we have to use that vaccine now. So it's, anybody can get it. Let's just get shot in arm. And so I was trying to convince, hey, patients, like 5:30 p.m. on a Tuesday, this is it. You get your opportunity. You're gonna move way up in line. And he was saying all the right things. I was asking what his perspective was. He says, it's todo es chisme. It's all gossip. I'm like, yes, you're right. There is a lot of gossip there. And it's puro político. Yeah, it's all political. You're right. There has been a lot of politics around this. So, let's go and get you the vaccine now. No, I don't want it. And it's like, oh, and it's really does, like, it takes me a moment to just breathe and relax and kind of come back to focus back on the patient. But he wouldn't do it because there's just, he's been reading what's on the internet. He talks to friends and neighbors, and there's enough suspicion, and it is based on, Fernando said, those historic antecedents of mistrust and a lack of understanding of what we're trying to do, and and some of the concepts around vaccination really need to be broken down. So unfortunately, I was not able to get that shot in that arm. With the next patient, I was successful. So of course it was used. We haven't wasted one. But it has been a different animal, and I think it's because of not only those antecedents, but the use of social media. There's been purposeful misinformation campaigns, and we as all of the above here, the providers, the leaders in religion and community and family, all really need to pull together. And I have seen, as those trends nationally and vaccine hesitancy have gone down, I've noticed that there's been a relaxing, and I've told patients, you're not the first person to get this. There's hundreds of millions of people around the planet now who have been vaccinated, and they talk about safety and efficacy issues.
And Charles, isn't it so factual that from a medical education standpoint, reaching the community is just so critical? Give them the information that they can use. And then let them speak among themselves, and make stronger and more educated decisions. When we leave, that vacuum, all of these social media, tactics can get in the way. And I think the folks that are listening to this program today just can have such a relevant part in that work. Get the messages out there that are from your voices.
Yeah, if I can pitch in, those are all really solid points. The last thing that I would offer is that this is a great example of the difference between equity and equality, right? That outreach, our communication around the vaccine can't be equal. Not every community needs the same kind of messages. We need an equitable response here that acknowledges the local history, the local culture, the local needs of that place, and most effectively communicates. So there's no one easy answer, and that puts remarkable strain on the public health system, which we haven't funded in a sufficient way, and we're seeing that with COVID.
Yeah, great points. A question did come in from the CEC text line, and I'll ask all of you, and if you can just quickly give me what you would give for this. What grade would you give the vaccine hesitancy initiatives so far that you've seen when it comes to for COVID-19 vaccines?
I think I would offer a B, recognizing that there are huge data gaps. We're still missing a lot of race ethnicity data in many places, and we need those kind of data to really evaluate our efforts. And the story, of course, varies from place to place. Not every state, not every county has been able to roll out things in the same kind of way.
Charles, Lionel, any grade, like when you first think about it in this space? And again, I think we all understand still a lot more can be done, but thus far, when you're thinking about it, as a initial grade that you think of?
Yeah, I think B is perfect, and can get better. It's encouraging to see, and I think I saw something recently that said now 70% of folks will actually get vaccinated. That's pretty cool. That's better than it was 2 months ago. So B, a lot more work to do, but I think we're on the right course. Can achieve if we're continue to be more forceful.
So in most medical schools, we use a pass-fail system. So I'm unfamiliar with these grades, but of course, we don't want to fail the country, because that doesn't give them much hope. But I'll give them a C, because I do think that coordination and messaging could have been performed a lot better. Obviously, it's a crisis, and I know the logistics are incredibly daunting. Even once we started to establish vaccination centers, it was still moving so back and forth on a routine basis as to who would be eligible, how to do it. That I think that could have been better done, and if we stuck more to a plan and a script, I think we'd have seen a smoother rollout.
Yeah, I'll just jump in there. And I think I agree with you, Charles. I think I give it a C. I think I'm still on the fence. I think time will tell. I think there have been some things that have done, but as we start, again, back to the data, and we look 6 months from now, are we at that 70% mark? Where are we exactly? And Derek, I think this will be a great question if we kind of lock this in and revisit and see how we are measuring up across the board. So I think time will tell. This one's not a polling everywhere question, but this is open to all of you. I know, Lionel, you have a passion in this area, and it's something that I think is on top of mind. Why is diversity and inclusion in clinical trials fundamental to improving health equity among Blacks and Latinx?
Yeah. Angela, you're right. I think it's just such an important topic. As we think of the pharmaceutical industry, drug development, R&D, the way that we identify molecules and put them through the different phases of development, we're doing it with intention, right? How to manage all populations and manage them to better health, particularly as we get to the point of commercializing the product, getting the product approved. So I think there's a very relevant argument to be made that, let's don't begin to think of health equity. Let's don't begin to think of the underrepresented population only when we're commercializing a drug. It really should be thought of at points of discovery, and it should be as part of phase 2 and phase 3 before we actually get NDA. So it is an area of passion for me, and thank you for recognizing that question. So I guess the point that I would make is that from a medical education standpoint, getting that across to healthcare professionals, making sure that we can get underrepresented populations enrolled in these clinical trials and begin to break down those barriers of trust and make sure they're engaged. Bring the topics of clinical trials to churches and to community centers and where people discuss health issues, I think is very, very important. Again, it goes back to including clinical trial topics as part of our direct-to-patient or direct-to-consumer activities. So thank you. That's a very relevant part of this conversation, I believe.
Charles, Fernando, anything to add when it comes to, talking about clinical trials and looking at improving, health and
I like the idea of having folks informing, not just including more people of color in the trials, but having more of the researchers from that background, from that culture as well, is very helpful, and also advisory boards that can help. Because I think that community education, and again, getting it from peers, would be very helpful. And I do see that there is to go directly into the community. If you're a large research-based corporation, say, can be difficult. You need someone to create that connectivity and that awareness, and so I think that those are very positive steps to take.
Yeah. Agreed, particularly if it's all supported by an educational infrastructure that reinforces the fact that race is socially constructed, right? So we want diversity in clinical trials, but not because race is a biologically meaningful category, but because it's a social category that has devastating and important implications in society. How we incorporate that into communication, into interpretation of data, so it doesn't result in race-based medicine, I think is a huge, huge challenge.
Great point. Another question came in from the CEC text line, and it goes back to the vaccine hesitancy. How do you address misinformation about vaccine hesitancy? It seems to be that hesitancy among people of color in some communities that are looking for vaccines in their communities, but there's no access in axing them. And it seems that, I guess, what do you do in those type of circumstances here and addressing misinformation about things not being available?
I think I'd like to take a stab at that one, because we were talking before about vaccine hesitancy, and these are still golden tickets. These are there's a lot of folks who want them, and my population is 80% prefer Spanish among my patients. They're almost exclusively below the poverty level, and so they really want this vaccine because they've seen what the infection has done to their neighbor, to their sister, to the people they know. And that's the kind of real life experience that they see every day. And they've been shut in their, in some cases, they've been really shut in their apartments for 9 months now. Really difficult quality of life, severe mental health issues. So I think that most of my patients don't have hesitancy. Most of them do want it. I do see a different pattern with this vaccine versus others, in that there's been pockets of resistance that are based on these on falsehoods that are spread through social media. In those cases, it's just a question of listening with empathy and explaining your perspective, personalizing it, and talking about how I've received the vaccine, and my parents have, my whole family will, when it's approved for children, my kids are going to get it too, I'm sure. But it's this larger issue also brought up with a very excellent question, very thoughtful, is getting the vaccine to the areas where it's needed, and that's I think starting to happen more routinely now that we're seeing it at job sites. We're seeing at community pharmacies, we're seeing in churches. And I think that when it's very, very widely available, that will be a game changer. Because there's also a little bit of maybe just some intransigence. I haven't, the individual may be thinking, I've heard that it's safe and effective. And I know that I've heard COVID-19 is pretty bad. They still have some doubts. I also heard this, that, and the other thing. But, it's right there, this Saturday, at my community center, at my church, in the local clinic, or at the pharmacy, and might as well get it. I think that will move a lot of people over into getting the vaccine if it's more widely available and they're not having to refresh their browser every 6 seconds.
Thank you. I'm just looking at time. I know there's some more questions here. Derek, can you pull up the next polling question? And again, I'll leave this open. over the past 6 months, has there been a change in how your local community has addressed health inequities in disadvantaged communities? So based off of your experience, and again, Fernando, you in Chicago, Charles, you in your area, Lionel, like everybody's all spread out. We got West Coast representation, Midwest, and East Coast. So any thoughts from what you've seen?
Yeah, I can share that in Chicago, I think in the past 6 months, momentum has been added to what we've been building over the past maybe 5 or 10 years. But 6 years ago, we had a Healthy Chicago 2.0 plan, which for the first time set out equity-based targets. So no longer looking at the city as a whole in terms of our public health measures, but breaking down the city into our community areas. We have 77 of them, recognizing the steep association between health outcomes and economic hardship and other structural and social determinants of health. And recognizing that the real goal is to break the link, right, between those structural issues and health outcomes. We have had a long-standing racial inequity in mortality. COVID is adding to that. It's adding a volatile new element to an already combustible mix. And it's important that we track that data, right? Otherwise, we'll diagnose the problem incorrectly. So over the past 6 months, I could say that we've reinforced messaging around the true causes of premature morbidity and premature mortality. It's not biology. It is not personal beliefs and behaviors. Those are important, of course, but they are shaped by social and structural factors. And if one benefit comes from the past 6 months is a strengthening of that message.
Yeah, the only thing I would add is that I think the vehicles that are available now and that the community is familiar with enables more health equity or health topics to get to Black and Latino communities. And I refer to Zoom a lot because that's how people are on Zoom a lot. And the programs that I see that are sponsored or unsponsored, people show up, to hear about their health and hear from physicians and other healthcare providers. And I think that's a real opportunity to bring health messages into the local community at the grassroots level, into people's homes. So an opportunity, and I think it's something that can continue to be helpful in terms of improving lives. And don't only use Zoom. I mean, a lot of people do not have good internet. So make sure that the telephone is kind of part of that solution as well. But it's about getting topics of health, into the community. I think it's very doable. And I see an upsurge of it.
All right. You know what? I'm sitting here looking at time, and I've gotten the 5-minute warning. I know we could probably talk about all of these different topics across the board. So I guess what I'd like to do is just quickly go around. As you look at the future, looking at 2021 and beyond, is there a top idea, top thing that you would like, or message that you would like to leave for our audience to think about, or things that may be on top of mind for yourself as we look, in 2021 and beyond?
Well, I started by discussing the fundamentals of one-on-one interactions and the small bits of kindness and healing that we do every day make a difference. If we can emerge from this pandemic and get to another side where we are in a much more stable place, there's going to be a ton of lessons to learn. We've been building this airplane while it's been flying, and I recognize all the difficulties inherent in that. So, but there are also good things such as telehealth that have come from this. What is our best use, and how do we apply that and leverage that moving forward? And I think that's where those larger structures that I mentioned earlier will come into play, and where systems and policy will be supportive, and we could, I think, really accelerate towards that utopian dream, much more quickly through the results of what we've done in this crisis.
Excellent. Fernando?
I guess looking in the near future, I hope we have a renewed recognition of the often invisible networks in our society, right? I think more people than ever before have talked about essential workers and have questioned, what is an essential worker? And the truth is that it runs the gamut, right? From very low paid occupations to very high paid occupations. And all of those networks have been made visible because they've been strained in this COVID epidemic. So in the future, maybe the visibility of those networks will give us greater insight into the ties that bind us all together and the real structural and social determinants of health inequities that have shaped not just COVID, but shaped before infant mortality and low birth weight, cancer and heart disease, and everything else that we tackle in the health system.
All right, and Lionel.
Yeah, very quickly, I would just, where we started, it's so important that medical education includes health equity as a part of any healthcare topic. That will certainly keep things progressing and at cornerstone and really enable change. So something to think of and something to consider.
Excellent. So again, I want to thank all of our panelists, Lionel, Charles, Fernando. Again, thank you for this dialogue, this particular session. I think the one thing that I have in 2021 is let's continue the conversation. I think the more we communicate with one another, understand what's happening in the community, that's where we're going to make the biggest difference. So I look forward to working with all of you. And again, thank you.
Thank you.
And yeah, thanks everyone. Great session. I appreciate all of you participating. And thanks to all of our participants as well for chiming in on Poll Everywhere. I thought that worked really great. And thanks again to Peer Audience for sponsoring that for us. Last couple slides before we finish up here. If you could take our survey, it's right on the live, excuse me, right on the live tab on our website. It's only 4 questions. We've decreased the amount of questions. So it really take you about 30 seconds to complete. So if you could do that, that would be fantastic. And then the last thing is to view the next session, which is Two Truths and a Lie, an in-depth look at the new ACCME standards for integrity and independence in accredited continuing education. You don't need to refresh your browser. You can just click on the link on the live page, and that will get started right at the top of the hour. So thanks again to our panel, and thanks to everyone else, and have a great day.
Thanks, everybody.
Stay well.